Hi, I'm Nikita Chennayagari, PGY2 Internal Medicine resident at Arkansas College of Osteopathic Medicine, Mercy Hospital, Fort Smith. I would like to share a unique case of adrenal histoplasmosis in an immunocompetent adult. As we are all aware, histoplasmosis is most prevalent endemic mycosis in United States along Ohio and Mississippi River valleys, commonly encountered in soils enriched with bird and bat feces. While most infections are asymptomatic or self-limited, some individuals develop acute pulmonary infections or severe and progressive disseminated infection. Disseminated histoplasmosis is commonly seen in immunocompromised patients such as patients with HIV infection and on immunosuppressant medications and can involve various organs such as liver, spleen, bone marrow, adrenal glands, and sometimes adrenal gland may be the only site of demonstrable disease. And disseminated histoplasmosis is rarely seen in immunocompetent host. In this clinical vignette, we want to report a case of adrenal histoplasmosis in an immunocompetent host. Patient is a 68-year-old white female with no medical comorbidities but has a 48-year smoking history. Presented to outpatient clinic for evaluation of symptoms of cough and chest congestion, and chest x-ray showed right upper lung nodule. Given her smoking history, we had a high index of suspicion for malignancy. To further assess the lung nodule, a chest CT was obtained which showed 2.1 centimeters cavitary mass along the pleural lining of right upper lung and incidentally showed bilateral adrenal gland enlargement, which you can see in the CT image here. 6 months prior to presentation, patient assisted in demolition of old abandoned house, which was thought to harbor bats and likely had an exposure to mold. During that time frame, she developed extreme fatigue, night sweats, and unintentional weight loss, which she eventually recovered in few months. On exam during the current visit, she did not show any signs of hyper or hypocortisolism. A whole body PET CT was obtained which showed hypermetabolic activity in bilateral adrenal glands, which you can see in the images here. And lab workup revealed normal adrenal gland secretory function, and the fungal infectious workup was done which showed elevated fungital beta-D-glucan assay and positive histoplasma antibody, while negative blastomyces antibody and HIV screen was negative. And blood work also revealed normal immunoglobulin levels. Adrenal gland biopsy showed necrotizing granuloma with yeast consistent with histoplasmosis and negative for malignancy or acid-fast bacilli infection. We suspected she likely developed disseminated histoplasmosis after her exposure in the fall last year. She was started on itraconazole 200 milligrams twice daily with a plan to treat for 1 year. Repeat adrenal function test was normal, and 6 months into the treatment, a repeat CT scan was obtained, which you can see here, which showed improved adrenal gland size. She continued to remain asymptomatic and tolerating itraconazole therapy. In our patient, our initial impression was lung malignancy given smoking history. However, a thorough history taking helped us to identify the exposure to bats and further broaden our differential to fungal etiology. On literature review, we identified many cases of adrenal histoplasmosis in immunosuppressed patients and only a handful in immunocompetent patients. And further, most of the case reports noted adrenal insufficiency. Even though adrenal histoplasmosis occurs in immunosuppressed patients, it does occur in immunocompetent patients such as our patient and must be considered in differential diagnosis of unilateral or bilateral adrenal masses presenting with or without adrenal insufficiency, especially in histoplasma endemic areas. And diagnosis of disseminated histoplasmosis is critical and requires high index of suspicion, especially in immunocompetent patients with non-specific symptoms. And this case shows how early diagnosis and treatment can prevent morbidity such as adrenal insufficiency and mortality in adrenal histoplasmosis. Thank you so much.